Welcome to Loud and Clear EMS Guiding Principles, where we provide high-level education for you, the providers on the streets, but connect all of that back to a set of guiding principles so that you never lose sight of what is actually important. I'm your host, Ross Orpit. I'm a former paramedic, now emergency physician with a subspecialty in EMS. Joined, as always, with me is my co-host, Will Berry.
Hey everybody, my name is Will. I am a flight paramedic in North Carolina.
In today's episode, we're diving into one of the most high-stakes scenarios in EMS, managing the agitated patient in the field. As mental health crises and polypharmacy overdoses rise, EMS providers are increasingly becoming the frontline response. These calls are fast-moving, unpredictable, and can quickly escalate into threats to both patient and provider safety. So how do we keep everyone safe? How do we intervene effectively and ethically and decisively? Our guest today is Patrick Hendley. Patrick is a practicing paramedic, a U.S. Coast Guard veteran, and an instructor in agitated patient management. With his help, we'll explore the pathophysiology behind agitation, the real-time impact of sympathetic nervous system activation, and the strategies that every EMS provider should have ready when things start to spiral. We'll also break down sedation choices, restraint use, and post-sedation care, all through the lens of real-world EMS principles: provider safety, community safety, transport safety, and ultimately the patient's safety. This is about more than de-escalation. This is about understanding what's really happening beneath the surface and acting fast and with purpose. Before we get into it though, when faced with a chaotic and out of control scene like you may encounter with an agitated patient, the tools you need to safely accomplish the mission need to be accessible in the most easy to find, easy to reach places. But this is not the luxury most of us have when we get to pack our own EMS kits. We didn't get to design these bags with our specific equipment or mission in mind. So we just put things where they happen to fit, not necessarily where they should be, to increase our efficiency and keep us safe. Enter today's sponsor, the Resuscitator. Their mission is to improve patient outcomes through the design of your bags. They can help you create a custom bag specifically designed for your equipment and your system so that your gear is exactly where you need it when you need it. If you work with the team at the Resuscitator, they will help you design a bag specific for you and your equipment from the ground up using the best practices of emergency care design. And then they will send you this prototype so that you can use it and reiterate on it before you make your final decision, assuring you get the bag just right. Reach out to them at theresuscitator.com to see how they can help you design better outcomes. Patrick, welcome to the show, and thanks so much for joining us.
Hey, it's great to be here.
So before we get going too far, I do want to start us off with a case. My partner and I were street corner posted when a call dropped only about a mile from where we were enjoying our coffee. The call was for a severely agitated patient, and the cops were already on scene. As we drove to the call, we keyed up on the police channel, told them we were en route. Their dispatcher politely but firmly told us that they were holding the air. That was our cue that the officers were on scene and something was there that they deemed unsafe. We rolled up to a residential block, houses lined up in a perfect row, 2 cop cars parked with their lights on, but they were empty. We looked and one officer was standing at the base of a stoop of a house. He was bladed towards the front door, which had nearly been broken off its hinges, and the residents stood in the door, yelling and pointing in the direction of the sidewalk. The officer's hand was at the ready on his weapon as he tried to listen to what they were yelling. We shifted our attention to the sidewalk, where we saw a towering figure walking away. This guy was huge. He's at least 6'4", no shirt, tattoos that looked like they were probably products of like a DIY prison artist, and he was strong. Prison strong. There was another officer who was anxiously following him, asking him to stop, but this guy wasn't stopping and he was covered with his own blood from a lac you could see on top of his head. You could tell right away he was hyperventilating and he was sweaty. My partner and I turned our attention back to the first officer at the door, who with a simple nod of his head indicated, "Go back to that guy. My partner with the Hulk needs your help." We caught up to that officer who was pleading with this guy to stop so we could all kind of talk and figure out what was happening. It was obvious pretty quickly by his words that he was delusional. He walked and talked about people spying on him, trying to kidnap him. He was saying people were trapped in the house, and he tried to break the door down. At one point, he pleaded that we needed to help him free his daughter who was stuck inside the house. My partner was able to talk to him for just enough time for me to get the story from the officer. Turns out they were called to a guy trying to force entry into a house. When that resident saw this towering figure trying to break his door down, he called the cops. As the door started to break in, he took a chair, broke it right over this guy's head, just like you'd see in a Hollywood bar fight. Well, the guy started to walk away as the cops pulled up. Now he's talking to us. We felt his pulse. It was fast. His skin, hot, sweaty. His speech, non-linear, paranoid, frantic. He wasn't making sense. At that point, my partner and I knew two things. First, this guy was going to the hospital for a probable drug ingestion. And second, we were probably going to have to sedate this guy, but what should we do to proceed? So Patrick, let's get into it. Let's talk a little bit about agitated patients.
Great. So we have a mental health crisis and a drug crisis here in the United States, and the problem of mental health and the problem of the severe drug overdose has outpaced our society's ability to come up with a definitive solution. So the problem has been pushed from the traditional healthcare system out onto the streets for us to manage. Traditionally, we haven't had the skills, the tools, or the training to properly manage these patients. These patients are very high risk to themselves, and they're very high risk to us as providers.
Yeah, so as we think about those things and as we approach these patients, what are going to be kind of our main principles that we're going to fall back on this episode?
So the first thing is think back to paramedic school, think back to EMT school, is safety. BSI, seen as safe. But we want to have a more nuanced approach to safety. So it's not just the word safety. It's safety of self and safety of our crew. It's our scene safety. Do we have a safe scene? It's transport safety. Can we initiate a safe transport? And do we have reason to believe that it's going to stay safe throughout transport? And then patient safety. Another thing we're going to want to think about is searching for and treating the underlying cause of the agitation. The agitation is not the patient's problem. It's a symptom of the patient's problem. The agitation might be our problem, and it might be the most salient thing for us to address, but it's not the patient's problem. And we need to search for that problem or those problems, and we need to address them. And then the last thing that we need to really think about is closely monitoring the patient's condition after any restraint or any sedation. These patients are high risk, they're dynamic, and they can change expeditiously, and it's on us to provide appropriate care.
Great. I think before we get into the weeds of how we exactly manage these patients, I think we should start maybe with some of that principle two you talked about, the underlying cause. So let's talk about the what and the why. What causes quote unquote agitation? What does that mean?
So in order to talk about agitation, we have to talk about the sympathetic nervous system. The sympathetic nervous system is our body's defense against threats and our body's defense against physiological insults. It's what our body does to protect itself and to keep itself safe and to fight illnesses, injuries, and threats. So think about the signs and the symptoms of a sympathetic nervous system activation. We get tachycardia, we get increased inotropy, we get vasoconstriction. That serves to shunt blood away from non-essential processes and to essential processes like large muscles. Our eyes dilate, meiosis, so we can collect more data. And then we get this emotional feeling of being ready to fight, or this emotional feeling of being ready to flee, or this emotional feeling of needing to freeze in place. That's why we call it our fight and flight system. And the secret third option we tend to not think about is freeze. So our fight, our flight, and our freeze. So what's that emotional feeling that we get, and why do we get it? That feeling is agitation, and the flip side of the coin is anxiety. That is our body's emotional response to danger. It's what gets us emotionally ready to fight or flee. So we get agitated, we get hostile, and we get ready to fight danger. Or we get anxious, we get flighty, and we have a hair trigger to flee or to paralyze and freeze in place. So that's what agitation is. It's a sign or a symptom of a sympathetic nervous system activation. It's our body's involuntary response to danger, and it's somewhat out of our control.
Is there anything that can make our patients more prone to agitation or acting unsafe because of their agitation?
Yeah, so our brain is this wonderfully complex organ, and we have this really amazing piece of it called the prefrontal cortex. The prefrontal cortex is everything that makes us a human. It's everything that separates us from the rest of the animal kingdom. It's what allows us to ration and to reason and to control our impulses and to understand our role in society and the long-term consequences of our actions. It's really great for long-term thinking and planning, and it's really good for very deliberate thought processes. This is that system 2 thinking that we have that other animals don't have. And it's really great for things like building civilization and creating art and engaging in medicine. But the problem is that in physiological time, it's very slow and it takes a long time to do. It's also physiologically very taxing. It requires a lot of glucose. It requires a lot of oxygen. It requires a very precise blood pressure. And so while it's really great at doing complex tasks and being creative, it's not good in emergencies. It's not fast enough to react to emergencies, and it requires too many resources that can be used elsewhere in emergencies. So the good thing is that when we experience stress or danger, and our prefrontal cortex becomes overwhelmed, we don't just shut down like a robot out of fuel. We can revert to more primitive and primal aspects of our brain, the limbic system and the hindbrain. So we have the human brain, and we have our mammal brain, and we have our lizard brain. Our human brain is great for thinking and processing, and our mammal and lizard brain is better for dealing with emergencies. So when your body is deprived of resources, like it's hypoglycemic or hypoxic, or when the body is experiencing environmental stress, we start to revert to this more primitive and primal form of thinking, and our threshold for controlling our impulses becomes smaller. So Will, let's say you have a splitting headache and you're in pain, and I say something that bothers you. Well, you're in your human brain mode right now. You're using your prefrontal cortex, and you'll think to yourself, gosh, that bothered me. But, we're doing a podcast right now. We're trying to record something. I'm just going to let that slide. I'm sure you didn't mean anything like that. But if you're hypoglycemic or you're hypoxic, or you're under the influence of a stimulant or a depressant, or you just underwent a traumatic incident or something like that, and you're back more in your mammal brain mode or your lizard brain mode, your threshold for managing that pain and controlling your impulses is much lower.
Can you talk a little bit about how drugs factor in, specifically drugs that mimic the sympathetic nervous system or stimulate it, like sympathomimetics?
Yeah, absolutely. So this is going to be one of our salient drugs, right, is our sympathomimetic. So methamphetamine, PCP, cocaine, they directly stimulate the sympathetic nervous system in an artificial way. So the problem with a sympathomimetic is the body cannot be experiencing any kind of stress or danger whatsoever, but the sympathetic nervous system will be activated. And all of the signs and symptoms that we think about when we experience danger or stress is going to be happening to the body no matter what we do. And that's going to be outside of the patient's control. They're going to be tachycardic. They're going to be hypertensive. They're going to be taking fast, deep breaths. They're going to have dilated pupils. And just as we can reliably predict that all of those things are going to happen with our patient, we can reliably predict that they're going to experience agitation and anxiety, and that their threshold for controlling their impulses is going to be lower.
I think this is really key, as I want to hone in on something you said, which is out of the patient's control. I think there's a misconception amongst a lot of pre-hospital providers and even emergency room providers that if I can just talk to this person the right way or cultivate the right environment, that I will be able to manage this agitation just with my words. Sure, that has its role, and I'm sure we're going to talk about verbally de-escalating these patients, but sometimes this pathology is out of their control and requires further treatment and intervention, and that's not your failure to take care of them.
Yeah, that's exactly right. I think it was Dr. Phil that said you can't reason someone out of a situation that they did not reason themselves into. I can't convince somebody to not be hypoglycemic. I can't convince someone the errors of being hypoxic. It's just something that happens to them. And drug toxicology, whether or not it was the patient's choice to take those drugs in the first place, at this point, once they're intoxicated, it doesn't matter whether it was their choice or not. Now their actions are going to be not within their control or much less within their control.
I really love that framework of understanding what's happening underneath the surface of this and that lack of impulse control. And rather than trying to blame them, treating it like an actual disease process, like we would hypoglycemia, and addressing the disease process. One of the other things I loved is before we started recording, you talked about being very thoughtful about what you called this training. Initially, you thought about calling it, the combative patient training, but instead decided to go with the term the agitated patient. And you had a wonderful reason for that. And I would love to hear you say that on the show.
Yeah. So when we thought about this, we thought about what's in it for us. They're dangerous for us. They're a danger to themselves. They can be a danger to the community. They're combative, right? How do we restrain them? How do we stop that combativeness? But what we came to realize is that agitation is a problem for them as well. And they have a problem that we need to solve. There's something underlying, there's something causing that agitation, and they need treatment for it.
Well, this hits at something else that is critically important for any pre-hospital provider, and that is to be able to use the appropriate terminology, just like we would with any other disease process. Agitation doesn't mean the exact same thing as combative, just like the word psychosis or paranoia or delusions. All of these words have different specific medical meanings, and we need to be able to use them appropriately so that we can appropriately describe what we're seeing and then appropriately describe what we're treating.
Yeah, absolutely. And another thing about thinking combativeness versus agitation, it helps us think more broadly about the patients that we're going to be managing and dealing with. When we hear the word combative, we think that we're going to be in a fight, and we think of the patient that Will was describing, the giant monster with tattoos on their face that's sweating and about ready to tear our head off. But what we tend not to think about is the 88-year-old female with COPD exacerbation who's batting away the CPAP that we're trying to give her. And so when we tunnel vision our thinking to just combativeness, we either run the risk of not applying appropriate concepts to our lesser forms of agitation or our less dangerous forms of agitation, or we run the risk of applying combative patient management concepts to patients that it's not necessary for.
And you had also mentioned to me this idea that when you use the term combative, you automatically get this thought of like an us versus them sort of scenario, when in reality, they're a patient and we should be working with them and with their disease process to come to a safe resolution and a safe treatment.
That's exactly right.
So with that in mind, let's jump into that first principle you talked about, which is the most important thing. As we understand what we're dealing with, as we understand this pathophysiology, as we approach this patient population, first and foremost, we need to make sure that everything is safe. And so we talk about this a lot in EMS, especially with these patients. The entire focus really should be on safety, but what does that mean? What is our safety hierarchy that you talked about at the beginning of this episode, and how do we work to ensure that everyone is safe?
So the first thing is, are we safe? Am I safe? Is my crew safe? Are we safe right here, right now? If that's not true, we need to exit the situation and we need to make ourselves safe. If we find that we're safe here, right now, in the moment, we need to address scene safety. Is the scene safe? Do I have a workspace to work in? And if not, I need to address that. Am I in an unfamiliar apartment building, a cramped space, a place where there could be hidden weapons? Some of these places we go into, it's like a Where's Waldo book of objects, and it's very easy to miss something dangerous. Am I on the side of a highway? Do I have traffic control? Do I have a safe workspace to begin managing this patient? so that I can take the time necessary to come up with an appropriate plan. And then something that I think is really important and something that us folks in ground can really take from the flight community is the concept of transport safety. Am I going to have a safe transport? Is my patient in a situation where I can manage them appropriately so that I can safely transport them and safely start the wheels? And is it going to stay that way? And if it doesn't stay that way, do I have a plan for managing them? We have an obligation as EMS providers to provide safe and professional transport. And that means the wheels need to stay on the ground, the operator needs to drive undistracted, the patient needs to stay on the stretcher with the seatbelts on, and we need to anticipate any problems that might occur with that. And the last thing is going to be patient safety. Patient safety is a concept that we see a lot in healthcare, and I think it's something that we can think about more in EMS. Patient safety is about reducing preventable harm and risk management. Now, notice I didn't say eliminating all potential for harm or eliminating all potential for risk. I said reducing preventable harm and risk management. So how can we think about how we're treating our patients so that we don't do further harm? And how can we think about managing our patients so that we can respond quickly and properly to any issues that they might have?
I'd love to run through these kind of one by one and just hear some concrete examples from you about how you approach and think about these patients. So when you're approaching an agitated patient, no matter the underlying cause, what are some things that are going through your mind about how you're going to keep yourself safe on that scene as you approach them?
So distance is going to be your friend. Distance is going to give you time and a reactionary gap. So it's just like driving safety. You give yourself time in between you and the vehicle in front of you because action is faster than reaction. So the action of brake lights in front of you is going to be faster than the reaction of you seeing the brake lights and applying the brakes and making the decision to apply the brakes. So that's going to be the same thing for our patients, is start with distance. Distance will give us time and a reactionary gap. So don't close the distance. Closing the distance can also increase the psychological pressure on the patient, and their threshold for fighting, fleeing, or freezing is going to be lower. So I may be able to comfortably get more closely to one of you guys if you're calling me for chest pain or, a minor injury, but somebody that is not in that headspace, they may perceive that as a threat and they may react to that threat much more quickly than what we would expect with other patients.
One thing I want to quickly talk about is never have we mentioned staging. And so I think that this is actually really important because there are a lot of systems that they shortcut a lot of this nuanced approach to safety and just say like, well, I'll stage and wait for PD to arrive. That doesn't always happen on every call. That doesn't always happen in every system. And that doesn't always ensure your safety. We're not always able to just wait and let someone else enter first. And that's not always appropriate if we think about some of the situations we go into. Safety is a constant evaluation that you're doing in real time of the situation you're in. And so I challenge you, you can't change your operation. If it's normal for you to stage and wait for PD, that's normal for you. But even if that's your normal operation, don't just assume that, well, just because an officer's there, it's safe for you to enter. Because what we're really talking about at that point is, I feel safer because there's someone on scene that has a gun. That's really at the end of the day what we're talking about, and that doesn't necessarily mean the situation is safer. And so being able to do this real-time assessment of all of these factors is critically important. And so this is why I think where we're going with this and what you're talking about, Patrick, is super helpful. Regarding managing the distance, 100% agree. I like to think about a concrete example of that is that gives me a little bit of time. They have to really take 1, 2, 3 steps to get their hands on me. They have to initiate some significant movements. The other thing is if I'm with a partner, approaching that patient almost in an L formation. So if they get agitated to the point where they want to put hands on somebody, they have to make a decision. Am I going to go for this person or that person? And then we can help each other out.
Yeah, I totally agree. And space for the patient as well. Be very mindful about putting them in a situation where they feel cornered. Make sure they have an avenue of escape. If their options are fight, flight, or freeze, you don't want to take away the flight option from them. Give them a place to run if that's what they feel like they need to do so that they don't resort to fighting you.
Absolutely.
Yeah, I love that. I think, we talk about does the patient have capacity? But again, your safety comes first. And so if the patient is agitated and the scene is unsafe and it is not going to be safe for you to control that scene, allowing them to exit the scene is often the safest possibility for you, who your safety is number one priority. And we talk a lot about knowing our exits, but I love the idea of making sure the patient has an exit too.
And there might be room for you to give them better options for their exit. So let their avenue of escape be off into the woods or off into an industrial area or something like that, not out into traffic.
That's really great forward thinking.
The other nuance I would throw in there too is there may be times where we have to take away their avenues of escape. Let's say they're in a situation where they might jump off of a high structure ledge. I've been on these calls where someone's on the top of a parking structure, that sort of thing, and you don't want them to jump. So those situations are very tenuous, very difficult. You're managing a lot at once. The key there, I think, is to make a plan. As long as you have time, you need to make sure everybody's on the same page so that if you are going to make a deliberate decision to take away a certain avenue for them and kind of force their hand in certain ways, that's done deliberately as a crew and as a team and as safely as possible.
Yeah, absolutely.
Yeah, these situations are highly variable, so dynamic, and there's a lot of nuance. So I love talking about the different approaches and the different scenarios where you're going to think differently about these patients, if I can say differently enough times. So we started to touch into the next point you said, which was community and scene safety. Do you have more you can talk about there?
Yeah, so community and scene safety is just, do you have a workspace that is safe? And if you don't, can you make it safe or can you change the workspace? So, Will, you were talking about tactics and things and staging earlier. Maybe if you don't have the luxury of staging and waiting for PD or another party to come check it out for you, maybe you have dispatch call back the RP and have them meet you out in the open so that you're not going into an enclosed space with them, an enclosed apartment building, things like that. Maybe you can get Department of Transportation or the fire department or supervisors of the crew to stop traffic for you so that you have a safer space. So it's about getting a safe workspace. It starts with preparation, like everything. Checking out your ambulance in the morning and making sure there's not things that can go flying in an accident or a hard turn, things that the patient can grab, all those kinds of things. So it's about having your workspace being safe, and that's the scene. And if you make the scene safe and you have a sense of containment, that will help keep the community safe as well.
Actually, a real story about this. My partner and I responded non-emergent to an apartment for low acuity complaint. It was just the two of us. When we knocked on the door, a voice said come in. So we cracked the door and we look and we saw a head poke around a corner and then run away and we heard a door slam. So we both were like, we're not going inside this place. So we did exactly what you described. We kind of made a decision. We're not going in, just the two of us. We had dispatch call them back and we had police come to help us. And then we also had dispatch tell the patient that we're not coming in, they needed to come out. And that ended up being what happened. And it ended up being a safe, non-confrontational resolution. And come to find out, our initial perception, this was an act that was maybe nefariously intended. There was a huge language barrier with this person, and there was a lot lost in translation. And once we actually got them out of the apartment and were able to engage with them, it made everybody breathe a sigh of relief. This person had no idea what was going on. That's why they did what they did.
Think of things in terms of scope of practice. So I'm not a firefighter. I don't go into burning buildings because that's outside of my scope of practice. I don't have the training, the experience, or the tools to do that. Now that I'm out of the Coast Guard, I don't go in helicopters like you do, Will. I don't have the training or experience to work in a helicopter, so I don't go there. As transport medics, we need to think about what training we've been given by our agencies or that we've received ourselves, and we need to stay within that training. And sometimes patients go into environments that are outside of our scope of practice. So I would not follow a patient into an uncontrolled apartment or room environment if I wasn't sure of their intentions, or if I had any doubt what their intentions or their ability to control their behavior was without somebody who is trained to do that, like a police officer. So think about what you're actually capable of doing and what the expectations are of you as a provider and what your role is. We tend to think we've been called here, we have to, at all costs, solve the issue at hand. And that's just not necessarily the case. We need to think about what our actual capabilities are.
Yeah, that risk benefit of your various actions. As we move from the scene and we start moving towards transport and thinking about transport safety, what are the things you're thinking about and how are you going to make that transport safe?
So transport safety is about keeping the wheels on the ground, keeping the patient on the stretcher with the belts on, having the operator be undistracted, and getting to the hospital without one of those things not happening. So patients may be very directable and very compliant when there's police on scene, social work on scene, family members on scene, when they're in a relatively calm environment, when there's nothing going on. A lot of patients that have psychiatric illness or they're under the influence of drugs or alcohol, their behavior is inherently unpredictable. Their threshold for managing their impulses is lower. So yeah, when they're sitting in their apartment and there's not a lot of stimulation and they're just talking to one paramedic, things might be fine. But then once we get into the ambulance, the bright lights of the inside of the ambulance go on. We start driving. Maybe a black SUV starts driving behind the ambulance, and all of a sudden they think the FBI is following us and their behavior changes. And that's not something that we can predict necessarily. So we need to think, how reliable is this patient's behavior? How redirectable are they? Can we ensure that when we engage in transport? And in these high octane situations where they're on the highway, traffic's shut down, we have a lot of providers on scene, something dramatic has happened with the patient's apprehension or getting them into custody. And once they're on the stretcher, people go, oh, okay, thank God that that's over. Let's get him in the ambulance, get him out there. Let's open up the highway. Let's clear. And this is where you as a provider need to think to yourself, hang on, slow down. Do I have a stable patient? Do I have a plan? Do I have the resources necessary in the ambulance to get to the hospital safely? Is there risk of my patient's condition re-escalating or deteriorating? And do I have the resources and plan necessary for that? And if the answer is no, you need to put your foot down and you need to say, everyone hang on. We need to give some time for the sedative to sit in. Or everyone hang on. I need a second rider. Everybody hang on. We need to reapply these restraints, whatever the case may be.
And then the last piece of that puzzle is the patient's safety.
Yeah, so patient safety is all about reducing preventable harm and risk management. Next is searching for the underlying cause of the patient's agitation and treating those underlying causes. Remember, agitation is a sign or a symptom. It's not the problem. It might be our problem, but it's not theirs. And we need to find out what that is. As paramedics, our job is to treat medical conditions, treat disease processes, treat toxicology, and to maintain patient safety. And we do that with a thorough assessment, searching for and treating underlying causes, and managing risk and having a plan.
I love that. I think we fall into this trap a lot in EMS with thinking that the symptom is the disease. We just talked about this in our syncope episode and how syncope is not a disease, it's a symptom of a different disease. And our job is to search for that other disease. The same thing is true here. Agitation is not the disease, and we need to search for the underlying cause for what is causing and leading to that agitation. So let's start searching for that. Tell me about how you're going to begin that.
We tend to think of agitation as a door with a lock on it. And all we have to do is walk up to the door, kick it open, and walk through, and our job is done. How we need to think of agitation is a door with multiple locks on it. And some of those locks are locked and some of them are unlocked. And our job is to find out which of those locks is locked, find the right key for each lock, and unlock the lock in turn, and then open the door and walk through it. So there could be one cause of the patient's agitation. There could be multiple causes, and we need to search for those causes, and we need to treat them all accordingly.
So let's start talking about what are the different causes and how are you looking, or how are you trying to tease these out?
So two of the big ones that we think about, and they illustrate a great point of how we start to deconstruct this, is going to be psychiatric crisis and sympathomimetic overdose. So for psychiatric crisis, this is the trickiest one because the underlying cause of psychosis and psychiatric crisis is some of the most convoluted, and there's not really a lot of agreed upon answers. But what we have come to understand is that antidopaminergics work very well for psychiatric crisis. So we have things like Geodon, droperidol, Zyprexa. These are all antidopaminergics, anti-serotonin agents. And this will it won't really address the root cause in the way that other agents will, but it will stop the process which is causing this sympathetic crisis with the patient. So we're directly addressing the cause of the patient's agitation, which is psychosis, with these agents. The next one that we think about is sympathomimetic overdose. So this is that walking up to the door and kicking it open and walking through. So we see somebody who's in crisis, in a drug overdose crisis, they're out of control, and we think, if I can just get close enough to hit him with a sedative, the job's done. We don't think about that with any other type of overdose. If somebody had a calcium channel blocker overdose, if somebody had a beta blocker overdose or an organophosphate overdose, we would think, what's the antidote or what's the supportive treatment for this overdose? And that's how we can think about overdose of sympathomimetics. So what is the antidote to a sympathomimetic overdose? Benzodiazepines. A lot of us have midazolam. That's going to be a great tool. So that midazolam will address the underlying cause, which is sympathetic crisis. So if we compare these two, if you gave droperidol to somebody with a sympathomimetic overdose, would it start to manage their behavior? Sure, it probably would. It might get them to sit still so that you could put the seatbelts on. But is it going to address the underlying cause? No, not likely. Yeah, you'll get them to lay there, but are you going to address the tachycardia, the hypertension, the hyperthermia? All of those things that are going to be swimming underneath the patient's level of consciousness. No, you won't, and you'll have missed out on an opportunity to do some benefit for that patient. So this is kind of a great example of searching for and treating the underlying cause of agitation.
Patrick, are there other examples of treating the underlying cause of agitation?
Yeah, so let's think about trauma. So what's going on in a trauma patient? So you have your trauma patient. They've gone over the handlebars of their motorcycle. They have a femur fracture. They have a humeral fracture. And now they're getting combative. You're trying to affix them to the backboard. You're trying to put them on the stretcher. They keep ripping their hands away and batting you away and trying to sit up, and you're having trouble managing them. So what you might think is, let's walk open to the door and kick it open. Let's grab a sedative and hit them with a sedative to get them under control. And ultimately, that might be what you have to do, right? But you could take another approach. If the patient is somewhat under control and you have a safe scene, you might think, okay, what's causing this patient to be agitated? Well, they've been in an accident. That's a very scary experience. Scary traumatic experiences activate our sympathetic nervous system, and they reduce our ability to control our impulses. They might be bleeding somewhere, hemorrhaging somewhere, so there might be a level of hypoxia involved. They're probably in pain. Pain is going to be something that's going to drive the sympathetic response. So how can we begin to address this? Well, oxygen. Oxygen's something that we're familiar with trauma patients. Let's try to get them some oxygen. It's probably something we should be doing anyways. Pain. We have a lot of tools for pain. Maybe we'll get something like fentanyl to start treating their pain. Fentanyl also has some anxiolytic properties that will start to address that fear that that patient's experiencing. So we'll give them some oxygen. We'll manage their pain. Maybe that will get them to calm down a little bit, and you don't have to reach for a classic sedative. Sedatives in trauma patients and in patients that you're perhaps going to have to intubate, that could do some further harm. If that's not working, you think, okay, well, I've given them some oxygen, I've treated their pain, I've given them an anxiolytic, and they're still kind of fighting me. I just don't think this transport's going to be safe. Yes, I have them under control right now, But once I start turning the wheels, is it going to stay that way? Well, then maybe you reach for some ketamine, some pain control dose ketamine. Ketamine has some dissociative properties that can help. It has some analgesic properties that can help. So you add that on top of what you've already done, and now maybe that gets them under control. You've taken somebody who might have gotten a dose of Versed or a sedation dose of ketamine, and you've been able to manage them with simple things like a little bit of oxygen, some pain control, and just a light touch of a sedative.
So Patrick, I like this approach for searching for the root cause of the anxiety. What kind of guidance do you give for a mixed presentation? Let's say somebody has schizophrenia that is dramatically out of control and they enjoy smoking crack, or they did some cocaine and they wrecked their motorcycle.
These are going to be some of our most challenging patients, and that's why this polypharmac overdose can be so high risk for us. So you take somebody that is in psychiatric crisis and they have a sympathomimetic overdose. So let's say we chose to treat the psychosis. So we reach for our antidopaminergic or reach for our antipsychotic and we treat that. Okay, the psychosis has gone away. However, we still have that sympathomimetic running rampant underneath the patient's condition. So we've gotten them to sit still, but we still have that sympathetic crisis. Now we go to treat that. Now we've paired a antidopaminergic or an antipsychotic on top of a benzodiazepine, and now we have a patient that is crumping on us. They're losing their airway, they're losing their ventilatory drive, and now we're having to perform way more interventions than we would have. So if you have a patient that is experiencing both psychosis and the sympathomimetic, I would tend to reach for treating the sympathomimetic first. And sometimes you're not going to know. And that's why planning and careful post-sedation monitoring is so important, because these patients can have multiple things going on with them. Another big pitfall that we can experience is assuming that they just have an upper. They're just on meth, they're just on cocaine. That's what's going on, because that's what we see right before our eyes. They're running around, they're hot, they're sweaty, they're kicking over trash cans. We think, man, this person is high as a kite. They're on some really severe form of upper. And we go and wow, I listened to the podcast. I know exactly what to do. I'm going to use a sympathomimetic antidote. I'm going to grab my midazolam or my benzodiazepine, whatever I have, and I'm going to treat that. And then once they calm down, we go, thank God that's over. And we stick our nose in our chart book. Well, come to find out later, that patient also was on fentanyl or some other kind of downer. And now you've paired a benzodiazepine with another downer and you have the same situation. You have a precipitously decompensating patient. So that's why post-sedation monitoring is so critical, because these patients can have diametrically opposed disease processes that you treat one and you potentiate the other, and you treat the other and you potentiate the first one. Or if you fail to treat the first one, you have an out-of-control patient.
Teases a little bit into the importance we're going to talk about in a second of the post-sedation monitoring. And I think, part of that is during our education on these episodes, we try to make this pathophysiology seem so simple, but in reality, it is not simple whatsoever. And what is going on underneath the skin and underneath the surface is very complex. And we can't always predict how patients are actually going to respond to any of the medications we use. But as we tease the different medications we're using for these different underlying causes, let's go through what we have in our toolkit. So let's say, first tool is verbal de-escalation. We always attempt verbal reasoning, verbal de-escalation, but for whatever reason, they're acting so illogically and not able to reason well enough for your safety, for their safety, and you feel like you do, for everyone's safety, need to proceed past verbal de-escalation. What do we have in our toolkit, and how do they work? How are you thinking about them differently for different diseases?
This is going to depend entirely on your system. So we have our benzodiazepines. Benzodiazepines are going to be great for sympathomimetic overdose. They're going to be great for postictal patients. They're going to be great for withdrawal patients, because the benzodiazepine is going to address the underlying cause of the patient's agitation. So in the case of sympathomimetic overdose, it's the antidote to that. In the case of the postictal state, it's going to address the underlying cause of seizure. In the case of withdrawal, you have a patient that's been under the influence of a depressive for a very, very long time, and now you've removed that depressive and their sympathetic nervous system is going crazy, and you're going to address that. And I want to take a moment to think outside the box a little bit with postictal patients and think about treating the underlying cause. What's the actual problem with someone who's postictal? The problem is that they just had a seizure and their brain is trying to reboot. Maybe a tool that we can use is time. We have addressed our safety. We know that we're safe. We have addressed our scene safety. We know that we have a safe workspace. Maybe we just give them some time to come out of it. Maybe that's all that we need. We don't necessarily need to rush into trying to control or sedate these people. They just had a seizure. They're sitting on the ground. We approach them. That agitates them and causes a little of aggression. We back off and we wait, and their agitation eases. Okay, let's give them some time. Now, as some time goes by, we talk to some family members, some people that know them, and say, hey, gosh, this has just been too long for them. Normally they're out by now. Well, then maybe we have to reevaluate. But the first thing we can try to do with them is time. So that's something to think about, treating the underlying cause, right?
I love that idea of using time as a tool as well. I love that thinking. So that's a great pearl. Also, as you're talking about this, the thing I think about with each of those disease processes is like an overactivity of the nervous system or a lack of activity of those GABA receptors, which shut down the nervous system. So when you have your benzodiazepines, they're going to work on those GABA receptors. They're going to shut down those overactive nerves, which is the problem. You have imbalance with your neurotransmitters that are activating your nerves in a sympathomimetic overdose. And so your GABA is going to balance that out again and shut down those nerves. In seizure patients, they have overactive nervous activity due to underlying pathophysiology in the brain from their epilepsy, and GABA receptors are going to shut that down. In alcohol withdrawal, you actually have a withdrawal of that GABA activation such that their nerves get inappropriately overactive. And again, benzodiazepines are going to act on those GABA receptors and shut that down. So what's our next class?
Well, let's talk about what things benzodiazepines are not great at doing. So benzodiazepines are not going to be the best selection for trauma because what they're going to do is they're going to blunt that sympathetic nervous system. Remember, the sympathetic nervous system is there to help us fight the fight. It's there to help us keep us alive. So if we're depending on our sympathetic nervous system to keep us alive, we don't want to add a benzo if we don't have to. Our hypoxic patients that are in severe extremities because of COPD or something like that, and they just won't tolerate our efforts to give them the things that they need, CPAP, a non-rebreather, or whatever. A benzo can work fine, but there are probably better things to reach for because, again, that patient's depending a lot on that sympathetic drive to stay in the fight, and we don't want to blunt that if we don't have to. So one of the next classes that we can talk about is our antipsychotics, and we've talked about that, anti-dopaminergics and anti-serotonin agents. So these things are great for psychosis. They work pretty well. They don't inhibit the ventilatory drive or hemodynamics as much as a benzodiazepine does. Now, that doesn't mean that there's zero effect because it certainly can, but it's going to have less of an impact than a benzo. So if you don't have to go with a benzo and you can treat just with one of the antipsychotics, that can be a good option. Another option we have is ketamine, which is predominantly NMDA active. It does have some GABA activity, but it just works in a different way. And it can actually be somewhat supportive of hemodynamics and the sympathetic nervous system. So if you have a patient that's depending on that for their survival in the case of trauma or hypoxia or something like that, or if you have an undifferentiated patient where you don't know what's going on, that can be a safe option. Or if you have an undifferentiated patient where you don't know what's causing the agitation, that can be a safer option. It's not 100% safe. Anytime you apply a dissociative or a sedative to a patient, there is a risk of it blunting something or changing something in their chemistry. And the patient's sympathetic nervous system depends on their catecholamine reserves. So if you have a patient that's been chronically ill or they've been under the influence of a sympathomimetic for a very long period of time, which some of these patients are, they can burn through those reserves. And even something like ketamine is going to have an impact on their ventilatory drive and their hemodynamics. So ketamine can be a great option for your hypoxic patients. If you absolutely have to sedate a trauma patient, ketamine can be good for that as well. And it's really great for undifferentiated patients.
And along with the antipsychotics, I'll throw in there, they are great for your intoxicated, agitated patient. Because as we talked about withdrawal, when the opposite of withdrawal, when somebody's alcohol intoxicated, they have already flooded those GABA receptors with that alcohol. And so benzo layering on top of that does create more of a dangerous situation with the respiratory depression. And something like an antipsychotic, which is not going to also layer on that GABA receptor, may be a safer option in those patients.
And let's not forget about other things like pain control and providing for the patient's comfort and de-escalation. These are things that we can add as well. Sometimes those light touches can make a big difference in the patient's behavior.
So we've talked about how these things alter our underlying pathophysiology. And I just alluded to the fact that, no one truly understands the pathophysiology that is occurring in these patients. It's very complex with overlying factors. So with that in mind, anytime you start affecting pathophysiology that you don't fully understand, you need to be prepared for adverse outcomes. Let's talk about the importance of the post-sedation period.
So this is where patient safety starts to become the forefront of our priorities. Patient safety is all about reducing preventable harm and risk management. It's not about eliminating all potential for harm or eliminating all potential for risk. It's about reducing preventable harm. So if you have an undifferentiated patient or you have a manifestly unsafe situation and you're starved of information, nobody is going to fault you for grabbing a benzo instead of ketamine or vice versa, or in some way zigging instead of zagging. People understand that you're going to have to make a decision based on the information you have and the tools that you have, and you're going to have to do something to control the situation. Afterwards, post-sedation monitoring is absolutely an expectation, and it absolutely must happen. And if you don't thoroughly examine your patient and monitor your patient afterwards, that is something that you're going to be held accountable for. So we've talked about the complexity of these patients and all of the things that can go wrong. We've talked about how they can re-escalate and how they can deteriorate. Full hemodynamic monitoring, full cardiac and respiratory monitoring is absolutely a requirement with anybody that you've sedated or otherwise restrained. These patients can be very sensitive to re-escalation and deterioration, and it can happen very quickly. So what does that mean? That means blood pressure on a quick turnaround, 3 to 5 minutes. That means at bare minimum a 4-lead, a 12-lead if you have the bandwidth and headspace to do that, because the 12-lead can illuminate some things going on underneath the surface. That means pulse oximetry. That means waveform capnography. And that means both of your eyeballs on the patient for the duration of transport. And that also means temperature monitoring. You don't have to necessarily take their temperature per se, but definitely do the old school back of the hand on the chest or on the core and see if they're warming up or if they're cooling down, see if they start sweating. So these things are absolutely something that we need to do and we need to document, and we need to have a hair trigger for acting on any changes that we see.
I would throw in there too, if you administered your sedative intramuscular, get an IV, and hopefully it goes without saying, but check a blood sugar, because the last thing you want to do is chalk everything up to something that wasn't hypoglycemia, and they were hypoglycemic. And on that, we also make that a very kind of polarized discussion. Very, very profoundly metabolically deranged patients from drug use can have deranged blood sugars as well. So it's not just about missing diabetes. It's about recognizing the complexity of this patient's presentation.
Absolutely. With medications, recall there's an onset of action, and then there's a further point of peak concentration. So when you see the medication start to take its effect, what you're seeing with the patient's behavior, they still have further to go. There's going to be more sedation that sets in with that patient. So what you don't want to do is see the sedative start to take its effect and go, this isn't the amount of sedation I want more, and then redose them before you've given some time for that peak sedation to take effect. And you need to recall that that peak sedation may take effect after you've already dropped them off from the hospital. So be very conscientious about after you've sedated them and after you've started to see the effects, they have further to go, and you need to monitor for that.
Yeah, that's so great. And I love what you said earlier about you will be forgiven. In EMS, we have to act on so little information with so little time often. And so it's easy to make a wrong decision if you zig instead of zag, and that is forgivable. What is not forgivable, and this is what I kind of think about a lot too when I don't know what's going on, is what's not forgivable is not correcting the ABCs, not recognizing a problem with the ABCs and not addressing and fixing and correcting it. So if you're having to act quickly with very little information, that should always be your primary focus, because that is the unforgivable thing, is not recognizing a problem with the ABCs. And so after you administer this sedative medication, even if you're not sure exactly what type of underlying etiology of agitation you are treating, so long as you stay focused on that patient safety when it comes to their ABCs, you can keep that patient safe on the way to the hospital.
So I want to focus in on this just a little bit, because we paint this conversation sometimes like it's all about our safety. And one of the things, Patrick, I think you're really bringing to light well is the patient's safety, their disease process, and their perspective. So yes, it's absolutely safer for us if we control their agitation, potentially give a sedative, potentially apply restraints. That's also safer for the patient, and many times if we allow them to stay agitated, especially let's say we're able to get them buckled and in restraints, but then maybe we do not treat their agitation or the underlying cause thereof, and we allow them to pull at the restraints, thrash around in the bed, bang their head against the stretcher. Is this really good for them? No. We should, I think, in these situations, really examine our threshold for administering sedative medications, because sometimes this is the most humane, the most comforting, and the safest treatment we can give to this patient. And in some places, I feel like it gets a little bit stigmatized by pre-hospital providers. That it's seen as maybe an extreme action or almost sometimes a failure of their ability to talk someone down. You really need to kind of put that out of your head, as you've mentioned. Like, there is an underlying pathology happening here that needs to be addressed.
I definitely hear what you're saying on the stigma, because I've seen that myself, especially when it comes to teens and children, because everything with children and pediatrics becomes 20 times more scary, right? But think about, you talked about what's most humane and what's most therapeutic for them. What's more therapeutic for a patient? Having 2 transport paramedics and 3 firefighters laying down on this patient, trying to force them into restraints, and having them seeing all this and experiencing all this when they're already in a high state of sympathetic activation? Or is applying a sedative and letting them just kind of disassociate? What is going to be a more traumatic experience for them? What is going to be worse for them? What is going to build trust with the healthcare system and build trust with EMS? And what's going to destroy, deteriorate, or sabotage trust with EMS? So which of those options is really better? There's absolutely a place and time for physical restraints, and that can be part of the calculation and one of the tools that we use. But sedation can be a much more therapeutic option. It doesn't come without risk, but fortunately, sedation, airway, and ventilatory monitoring is something that EMTs and paramedics are already really good at. So it's something that we're really poised to manage.
One thing we haven't talked about yet, which we probably should, is restraints. Let's talk a little bit about restraints, when to use them, how to use them properly. How do you think about them?
So how I think about restraints is I think about the old phrase, locks keep honest people honest. So what that means is if you have somebody who wants to break into your home, they're going to break into your home. Having a lock on the door is not going to change that. What that does is that prevents casual, opportunistic entry into your home. Somebody just going, well, let me go snoop around. That's what it stops. So what I think about with restraints is restraints keep compliant people compliant. So you have somebody who's under arrest or on a psychiatric hold, or someone who's agitated, but they're otherwise somewhat directable, and you're able to coax them onto the stretcher. You're able to get them into the ambulance. Restraints are a great way of keeping them that way. And in the event of a escalation or a re-escalation, or they change their mind, or manipulative behavior, buys you time to get a different tool, which would be sedation. In my opinion, physical restraint should not be a primary tool for somebody who's actively fighting and actively resisting, because there is a danger of them harming themselves. There's a danger of them breaking out of the restraints. They can harm themselves. It can be really dangerous for a patient that has a seizure. So physical restraints are, for me, something that keeps a compliant patient compliant and buys me time to get different options if that's what I need to do. It's also a bridge to sedation.
Do you talk about every system is different, and obviously you need to follow your policy, your protocol, but do you have any practical advice for safe restraining techniques?
Yeah, so I think a simple step that people can take is to get purpose-built restraints that are designed for that function if you don't already have them. Triangle bandages and cravats and things are not great options if that's all you have, but they can break easily. They're difficult to apply under stress, and the potential for harm is greater. So that would be a really easy win for people, is get purpose-built restraints if you don't already have them. Velcro restraints are probably best. There are models that use like a handcuff key or something like that. I would pause before introducing that into your system. That's an item that requires fine motor skills to operate under stress. It's another tool that can get lost really easily. It requires more training. The Velcro ones are easier to use.
If you're in a system where the restraints are stored separate from your stretcher, the time to unwrap them and attach them is not when you're in the middle of a situation where you're trying to apply them. So
absolutely.
Having them staged appropriately, whatever's most appropriate in your system. Some places keep them on the stretcher, which I think is a safe and reasonable thing to do. If that's not what you do in your system, then having them out and ready on that call where you've decided they're going to be used is good. Not when you've dogpiled the patient and then someone's like, they're up in that cabinet. That's poor practice, in my opinion.
Yeah. Another note on patient safety-centered care with the restraints. A lot of systems have it in their protocols for one arm up, one arm down. That comes from the hospital system, and it comes from people being in bed supine and not wanting them to roll over. In the ambulance environment, it's a different calculation. A hospital bed isn't moving, and an ambulance is. If you have one arm up over the patient's head and there's even a low velocity vehicle accident or a hard stop, that can put their shoulder in a very precarious situation. And you have now taken somebody who, by the very nature of the fact that you restrain them, could not make their own decisions and are essentially vulnerable, and you've put them in a situation that is worse for them, and now they suffered an injury because of something we did. So I understand the rationale of putting an arm over the head because you don't want them to sit up and thrash or slip their belts. But my thinking is, if your patient is that agitated and that difficult to manage, you probably should be reaching for another tool.
I want to back up a little bit too and just talk about how we get to that point. I think you can't make a rule for all of these situations. They're very dynamic, but safety in numbers, the more people you can have on scene, the better. The more help you can have if you're going to restrain someone, the better. The earlier I can ask the patient or try to get the patient into a seated position, that helps too. a very dangerous maneuver is trying to get someone from standing all the way down. They're at risk of falling, hitting their head. You can have like a fall on an outstretched arm type injury. Providers can fall on top of them, or the patient can take you down. So lowering the stretcher early into the call to like the height of a chair, I think is really important. Getting it all set up so that we have a landing zone. If something happens, like sometimes you'll be on these calls, someone is, their tone of voice is very elevated. Maybe they're yelling at you, but something in them, they see the stretcher, they see the ambulance, they know I'm going. And then all of a sudden they just flop down on the stretcher and say like, okay, let's go. And you're like, oh, that was easy. And now we're already on our stretcher. That's great. So lower the stretcher down, open the belts up early in the call as you can. And in that way too, if we need to restrain, we need to go hands-on, or we need somewhere to put the patient, we already have our safe environment there that's padded, and that's where we want them to be anyway. So we can go to the stretcher, then we can apply the seatbelts, apply the restraints. A very practical rule is if we have to go hands-on, we need to go all the way. And what I mean by that is not something violent or aggressive. I mean, if I grab one arm and I'm expecting you to grab the other and you don't, well, then that patient has an arm free to potentially hurt or swing themselves or me. So if we do go hands-on, we need to control all four extremities, and we need to quickly get them in our padded restraints to prevent any violent action, because it's not only danger to us, it's again a danger to the patient.
I forget the exact statistic, but in the law enforcement community, there is a statistic about when assaults on police officers happen, and the highest percentage of assaults happen at point of first contact, physical contact. So the moment the individual is touched, that's when the assault is most likely to occur. I would add, for anyone who's thinking about adding this into their training regime or their training regiment, good for you. It's absolutely something that should happen. It's one of the highest risk things we do as providers. Think of this holistically. Invite your stretcher management trainers and your emergency vehicle operator trainers to the planning session so that you can have a holistic, safety-centered mindset on this training.
That's great advice.
Once they go on, they shouldn't go off. Once your restraints are applied, don't take them off. Now, follow your local policy and protocol. But the heart behind that, and what I'm really saying is, if something happened in your interaction with this patient where you deemed it necessary for your safety and theirs for restraints to go on and sedation to be applied, keep that posture and that mindset through your entire patient interaction, because things can change and their situation is going to remain dynamic. In the grand scheme of things, the 15, 20 minutes you're with them, maybe even up to an hour, that's a blip on the radar screen in terms of their whole care. Keep the restraints on, manage them appropriately. Obviously, you can, if you're worried that, oh, maybe they're too tight or they're hurting the patient, don't remove them. If you've made the decision that it was most appropriate for safety reasons to put restraints on, leave them on until you get to the hospital and the patient can be reassessed with more providers and more tools. The last thing you want to do is unrestrain the patient in the back of the ambulance with maybe just you, because you're thinking, oh, well, they seem more calm now, or it seems like things kind of work themselves out. And then you have an even more dangerous situation for you. There are stories of people jumping out of the back of moving ambulances. Those situations are incredibly dangerous for everyone involved.
That's exactly right. We talk a lot about in the hospital, there's heavy importance on trying to get those restraints off as quickly as is safely possible. But just as you mentioned, in the hospital, we have security, we have a ton of staff. We're not trapped in a confined space with the individual. And so I do think that the pre-hospital environment is not the safe space to determine if it is time for those restraints to come off. And I think it's okay for those to stay on during transport until that decision can be thoughtfully made with more resources in the hospital. Now, as we arrive to the hospital, let's talk about the importance of that handoff, that communication to the hospital staff and creating that shared mental model. How can we effectively transfer the care of this complex patient?
So I love what you said about having a shared mental model. Think about it from the perspective of the receiving hospital team, the nurses, the doctors, the pharmacists, RT, everyone's there. So you have this big dramatic call with the highway shut down and this hot, sweaty, raging patient. And it was this whole 45-minute ordeal. And you took the time to identify the underlying causes and you address them appropriately. And there was this big confrontation with the police and this big fight to get them on the stretcher and this whole dramatic episode. And the receiving hospital team sees somebody sleeping peacefully on the stretcher. The story is simple. The facts of the case are simple. The person was highly agitated. I applied a sedative. I monitored them. I brought them in. That's the facts of the story, right? But that receiving team has no idea the degree or the severity of that patient's disease process. A patient who is somewhat paranoid, they don't want to sit on the stretcher, they keep trying to get up, so you offer them some oral Zyprexa to help them calm down. They take it, they sit down, it kicks in, and then you bring them in, is a very different patient than the one where you've shut down the whole neighborhood and 4 police officers had to pile on them to get them under control. They were hot, they were sweaty and tachycardic. You had to apply a sedative. The taser was deployed. Those 2 patients are very different. The patient that was wandering around being a nuisance in the community and the patient that was shooed out of a 7-Eleven at 8 o'clock in the morning, and then now you're picking them up 10 hours later in the next city over because they power walked in 98-degree weather, roaring at the top of their lungs for the past 10 hours. Those 2 patients have a very different disease process. And the way you communicate that is with that shared mental model. So make sure that you illustrate to the receiving team what you encountered. So I arrived on scene. There were 4 police officers holding them down. The taser was deployed at least twice. They were very tachycardic. They were hot. They were sweaty. It was about 98 degrees outside. Bystanders said that they had been out there for the past 5 hours at the very least. We applied a sedative. They fought through the sedative for about 10 minutes. We finally got them under control and we were able to apply physical restraints. We had to redose them with a sedative a second time. We're here now. Their heart rate has gone down. Their skin signs have improved. Their hypertension's alleviated. And they're ventilating spontaneously. Do you have any questions for me? So that really communicates to the receiving team how severe or not severe the disease process was.
We can't forget that the patient's care is a continuity of care, that it doesn't begin and end in the field, or it doesn't begin and end in the hospital, that it begins in the field and it continues through the hospital. And both parties need to recognize that. I can't do my job effectively without the information that is provided to me by the pre-hospital team. So what you do and what you collect and what you see and the history you take truly matters, because things change and sometimes I will never have access to the information you had access to. And that's why it's important for, in my opinion, the entire healthcare team to be there, the nurse, the tech, the doc, just as you said, so that we can all have that shared mental model and continue that patient's care throughout their course seamlessly. Once they're in the hospital, I'm going to do pretty much exactly what you have done thus far in the pre-hospital setting. First and foremost, this is something we didn't talk about. We kind of operated under the assumption that this was a patient. First and foremost, in the pre-hospital setting or in the hospital, you need to determine, is this even a patient? Is this person experiencing potentially a medical crisis that is threatening their safety or threatening the community's safety? Once you've determined, yes, they're a patient, you need to determine, do they have capacity to accept my medical care or refuse my medical care? And if they do not have capacity and they are a patient and you are worried about their safety, then we progress down the lines as we've talked with this entire episode. And sometimes you have to do that very quickly with very limited information, and it can be challenging, but you do the best that you can. And I'm going to do the same thing in the hospital. After that, I'm going to search for the underlying cause, just as you have, with historical features, a lot of which are probably going to be provided by you, or if we can get a bystander to come to the hospital, family members, bystanders. After that, based on my concerns for the underlying cause, I'm just going to start doing tests to make sure that there's no, electrolyte derangements, laboratory derangements, if there's concern for a head bleed, possibly a CT of the head, and, trying to elicit any sort of ingestions and stuff like that. And if any of those are present and if any vitals are abnormal, we'll start trying to see if we need to treat those and make those better. That's what's going to happen for these patients in the emergency department. If there is a true medical emergency that I cannot fix in the short 4 to 12 hour period in the emergency department, they'll be admitted to the hospital. But oftentimes it is about addressing that underlying problem, stabilizing that medical emergency, and with the tool of time, as you just mentioned, a lot of these medical emergencies we can fix and support the patient through with medications, fluids, and correcting abnormal vitals or abnormal laboratories.
When you're in the field with these patients, you need to remember you're being video recorded. If it's not a bystander, it could be a police officer's body-worn camera. So your behavior, your tone of voice, your posture, everything matters. You need to keep your speech professional. You need to keep it medically centered, and also be very vigilant about your body language for not just how it appears on camera. The camera could be a cue for you to check your body language, but it also matters significantly for how your patient is perceiving it. If you have your arms crossed, or you have balled fists, or you look like you're ready to fight, well, then that puts them in the headspace where they want to as well. If your hands are up, kind of disarmed, and you kind of have that posture of, hey, I'm just trying to figure out what's going on here. Well, that is a disarming posture towards your patient, but also your hands are up kind of in the middle of your body where you could push away a threat if you needed to. And on camera, it doesn't look like you're being aggressive, which is also kind of a win there too. But remember, you're always being recorded. These are very difficult situations to manage, and they're very, very dynamic.
Yeah, the prefrontal cortex thinks in words, and it thinks in stories, and that's how it communicates. The mammal brain and the lizard brain thinks in body language. So people that are in that headspace are going to be much more sensitive to body language than the rest of us. And their threshold for tolerating even small nuances in body language is going to be much more heightened. Mentally ill people in particular are very sensitive to body language. People with paranoid ideation can be very, very sensitive to eye contact and can find it to be very invasive. So being very mindful, remember these people have less, or they potentially have less impulse control, and they might be more sensitive to things that to us seem innocuous. So totally agree with that.
All right, Patrick, can you summarize everything we just talked about, connect that back to those principles we started with?
Absolutely. So remember, patients that are experiencing agitation, it is a sign or a symptom of something else going on. Try to find out what that is or what those are. Once you've identified a working diagnosis and you've addressed the underlying cause, keep searching, keep digging. Particularly when you find patients that are out, they're roaming around, they've been outside for a long time, you don't know what their story is. Sure, it might be just that they're on drugs, or it might be just that they have psychosis. It might be just that they're drunk. But it could also be that they've been assaulted or robbed or hit by a car, or that they have chronic medical conditions. So keep digging. Work with your working diagnosis, but don't lose sight of having a wide differential. Do your altered mental status rule-outs. Do your agitation rule-outs. Have full hemodynamic, cardiac, ventilatory, respiratory monitoring, temperature monitoring. Do a thorough physical exam. Collect as much history as you can to the extent that you can, and make sure that your safety comes first and that you have a safe transport.
That's great. Thank you so much for joining us today. That wraps up this episode on agitated patient management. Remember the core principles we started with. Your safety and your crew's safety always comes first. From the scene to transport, every decision must aim to stabilize, protect, and uncover the underlying cause of agitation. Whether you're managing a psychiatric crisis, a polypharmacy overdose, or something that doesn't fit neatly into a textbook, full cardiac, respiratory, and hemodynamic monitoring are going to be your lifeline, both clinically and legally. And if you take just one thing away from today, prepare for change. These patients are dynamic. Their condition and the risk can escalate or decompensate in moments. If you found this episode helpful, do us a favor, share it with your crew, leave a review, and hit the subscribe button so you never miss an update. Follow us on Instagram at EMS Loud and Clear, and check out our website at emspodcast.com, where you can find blog posts and bonus materials for most of the episodes. Thanks for joining us. We'll see you next time with more real-world tactics and insights to help you bring calm to chaos and bring your patients safely through the storm.